Hello, good afternoon. My name is Albert Opoku. I'm one of the consultants at the Homerton Fertility Center. This afternoon, we're just having a chat about the use of adjuncts in assisted reproduction. Recently, there's been, both in the mainstream media and in ART circles, lots of news about using adjuncts in ART circles. The main issue with these adjuncts has been the lack of evidence for their use. There's often not much robust evidence, and most of the evidence has been anecdotal. One of such adjuncts which is used currently is dihydroepiandrosterone, or DHEA for short. This is currently being used in certain circles as it's thought to improve ART outcomes in poor responders. Dihydroepiandrosterone, or DHEA, is a naturally occurring androgen produced mainly by the adrenal glands, but it's also produced by the ovaries. In postmenopausal women, it contributes to the majority of the androgen content of their body. It also is peripherally converted to estrogens and androgens, and this is where its use in IVF came about. Because it's peripherally converted to androgens, it's thought to enhance or to be useful for aging, so it's been used both as an anti-aging agent and also as a sports enhancing agent because of its androgenic properties. Back in 2000 was the first time that it was reported by Carson and Co. That it could be used in IVF. 5 women were given supplements of DHEA, and these women were going through IUI treatments, and in that time it was thought to have improved their estrogen production, and in the 5 women there was 1 pregnancy. Not much was heard about this until about 2005, where a group in New York started using DHEA. The initial case was about 1 woman who was known to have a poor ovarian reserve. She sought out DHEA and used it herself and produced 66 follicles not in one cycle, in several cycles. She used DHEA consecutively and produced several follicles and had many frozen embryos from being a poor responder. This led to a lot of interest in the use of DHEA, and since then it's been used in different settings and different scenarios. And the general anecdotal evidence is that it improves IVF outcomes in poor responders. It's thought to improve the ovarian count, is thought to improve the AMH levels, it's thought to reduce miscarriage rates, and also improves live birth outcomes. The main issue with DHEA is that to date nobody can tell us specifically how it works. There are different postulates as to how it works. The initial postulate was that it improved the ovarian stimulation through a paracrine IGF-like effect. This was discounted as they were found to be a group of people who managed to produce oocytes without having IGF-1. Then there was a thought that it's because of the peripheral conversion to estradiol, it boosts either oogenesis and folliculogenesis through sensitizing to FSH stimulation. Also, it's thought to decrease ovarian apoptosis, therefore increasing the follicular pool for stimulation. And then there was a thinking that it also changes the environmental milieu in the oocytes such that it reduces aneuploidies. None of these theories have been categorically proven. The other question with DHEA is that there's never been a set dose. In the different studies, which are all very heterogenic, looking at lots of different factors, they've used doses of either 25 milligrams 3 times a day, or 75 milligrams once a day, and again being given in different durations. There have been some systematic reviews and meta-analysis looking at the use of DHEA and androgens in general in IVF cycles. All of these analyses have ended up concluding that although there might be some evidence to show that it improves outcomes, there is no statistically significant evidence that it does, and as always recommended that there should be a large-scale, well-structured trial to look at the role of DHEA in IVF. In 2015, there was a Cochrane review on the use of androgens, and they looked at both testosterone and DHEA, and that again said that if you combine all the studies that they looked at, then there was evidence that DHEA improved outcomes. But if you restricted the analysis to the randomized trials and the well-structured trials, then there was no evidence of this effect. In 2017, there's also been a meta-analysis from Japan with very similar results, saying that if you combine all the studies, then there is a positive effect of DHEA, but if you restrict your analysis to the well-structured trials, then there is no such effect. At present, there's a very large, well-structured trial about to start recruitment here in the UK, in our center. It is a multi-center, placebo-controlled, randomized, double-blind randomized trial, which is in 6 leading UK centers. We'll be using 75 milligrams of DHEA. In women, there's a set inclusion criteria based on the Bologna criteria. These women are going to have 3 months of DHEA supplementation using 75 milligrams daily, and we are going to assess their AMH before and after DHEA supplementation, as well as their IVF outcomes after a standard IVF treatment protocol. As I mentioned, this trial is just about to start recruitment. It is well powered to answer the question of whether DHEA improves outcomes in women who are poor responders to IVF, and hopefully we will be able to provide the required evidence either for the use of DHEA or to be able to give informed choices to patients on the case. Thank you very much.